Hello everyone, we'll be discussing about ductal patency and closure in this lecture. To view the previous lecture on history and embryology, please follow the link which has been provided. In this particular lecture, we'll first learn about all the mechanisms of how a fetus is able to maintain his ductal patency, following which we'll see how a ductus closes after birth. In utero, the patency of ductus is mainly regulated by hypoxia, prostaglandins, and nitric oxide. There are other factors like adenosine, bradykinin, noradrenaline, and acetylcholine, but their importance, it hasn't been established much, and therefore we'll focus on what all has been established. Hypoxia is the most important factor in maintaining ductal patency. Antenatally, the partial pressure of oxygen within the ductus is 18 millimeters of mercury, and that in the vessels which are supplying the ductus or in vasa vasorum is 26 millimeters of mercury. We know that postnatally this becomes 90 to 100 millimeters of mercury. And therefore it was thought that oxygen does have some role to play in ductal closure. Several experiments were conducted in guinea pigs, fetal lambs, and isolated perfused ductal rings which confirmed this particular finding. In isolated ductal ring experiments, they found that the ductus is completely dilated when the partial pressure of oxygen is somewhere between 20 to 35 millimeters of mercury, and increasing or decreasing the partial pressure of oxygen will lead to ductal closure. In this graph, if x-axis is representing the partial pressure of oxygen of the fluid wherein the isolated ductal ring is perfused, and y-axis is representing the intraductal tension, this is the point of minimal tension. And at minimal tension, it means the ductus is maximally relaxed. The partial pressure of oxygen is 20 to 35 millimeters of mercury. Increasing or decreasing the partial pressure of oxygen leads to an increase in intraductal tension or leads to ductal closure. A significant amount of contraction, it begins when the partial pressure of oxygen is somewhere between 40 to 50 millimeters of mercury, and this corresponds to a saturation of around 75%. Maximal contraction or maximum intensity of contraction is seen when the partial pressure of oxygen is between 120 to 150 millimeters of mercury, corresponding to a saturation of 100%. And a similar intensity of contraction, a higher intensity of contraction, is also observed when the partial pressure of oxygen is 5 to 8 millimeters of mercury. But how does ductus close in response to oxygen? There are various theories which have been put forth for that. And the most important theory is oxygen acting on oxygen-sensitive potassium channels. Oxygen tends to inhibit these oxygen-sensitive potassium channel, leading to depolarization, activation of L-type calcium channel, and increase in an intracytosolic calcium, leading to ductal contraction. These oxygen-sensitive potassium channels, they are developmentally regulated. Meaning that if we observe a preterm, the concentration of these oxygen-sensitive potassium channels will be very low compared to a term-born child, and therefore there are higher chances of a preterm having a patent ductus compared to a term child. We can therefore state that response of ductus to oxygen is related to fetal gestational age. In studies of perfused fetal lamb ductus preparations, again the x-axis representing partial pressure of oxygen and y-axis representing the intraductal tension, it has been seen that the ductus does not constrict in a premature fetus, even when the partial pressure of oxygen is raised to as high as 500 to 600 millimeters of mercury, and the responsiveness of oxygen, it basically increases with advancing gestational age, requiring lesser amounts of oxygen as the gestation increases and the ductus becomes more sensitive to oxygen. This is basically the first mechanism of how oxygen leads to changes in intraductal tension. The second is a direct action. Oxygen also tends to have a direct action on these L-type calcium channels, and this particular mechanism is completely absent in a preterm child. However, it has been seen that when we introduce a chemical or molecule called BAYK8644, which is basically a calcium channel opener, to a preterm child who is not responding to COX inhibitors, it has been seen that the ductus constricts to a similar intensity or similar magnitude to that seen in a term child. The second mechanism is prostaglandins. we have two COX enzymes, COX-1 and COX-2. COX-1 being a housekeeping enzyme, and COX-2 is implicated in inflammatory responses. But both of these enzymes are implicated in maintaining ductal patency. COX basically converts arachidonic acid into prostaglandins. We have two prostaglandins, PGE2 and PGI2, which are implicated in ductal patency. PGE2 is mainly formed by placenta, and PGI2 is mainly formed by ductus. The ductus is 1,000 times more sensitive to PGE2 compared to PGI2, and therefore when it comes to maintaining the ductal patency, we talk about PGE2. Please note that alprostadil is neither PGE2 nor PGI2, it is PGE1. Now when the child is born, there is no placental source of PGE2 which is remaining. The only PGE2 which is available, it is which is present in circulation. It ultimately gets metabolized in lungs, and in absence of PGE2, the ductus constricts. However, when we talk about preemies, their lungs are usually immature, and usually it takes a prolonged time for them to metabolize the entire PGE2 which is circulating, and hence a prolonged patency of ductus in preemies. The third mechanism is nitric oxide. The very first important point to note in case of nitric oxide is that the more preterm or premature a child is, the more it depends upon nitric oxide as the primary pathway of ductal patency. As the fetus reaches term gestation, it switches over to depending upon prostaglandins as the primary pathway for maintaining ductal patency. In that same tune, it has also been observed that when you add L-nitroarginine, also known as LNNA, which is a nitric oxide synthetase inhibitor, to a preemie who is poorly responsive to COX inhibitor, it increases the chance of ductal closure in that preemie. Now, just for completion's sake, nitric oxide is synthesized within the endothelial cells using endothelially derived nitric oxide synthetase. L-arginine basically gets converted into L-citrulline, releases nitric oxide. From endothelial cell, it is taken over by the smooth muscle cells, where it causes dilatation of smooth muscle cells. To summarize, ductal patency in utero, it is maintained mainly by hypoxia, and we have oxygen-dependent potassium channels which are implicated. Then we have prostaglandins, we have two COX enzymes and two prostaglandins. PGE2 is more important compared to PGI2, and PGE2 is formed mainly by placenta. It is also formed by ductus, but ductus mainly forms PGI2. And then we have nitric oxides. The more preterm a fetus is, the more it depends upon nitric oxide pathway for ductal patency. As the fetus reaches term gestation, it switches over to depending upon prostaglandins. Now that we understand how a ductus remains patent in utero, we'll see how the ductus closes after birth. Initially, we have something called a functional closure, which is followed by an anatomical closure. Functional closure, to put in plain words, it is just a smooth muscle contraction, and therefore it can relax again. Whereas this anatomical closure is basically fibrosis which happens, and it cannot reopen once fibrosis sets in, because we get something called as ligamentum arteriosum. In 44% of term-born infants, the ductus will functionally close within the first 8 hours of life, and in almost all the term-born infants, it will get functionally closed by 72 hours of life. We've already read all these mechanisms of functional closure. We know that there's a decreased concentration of prostaglandins because of loss of placenta and increased metabolism by the lungs, and also there is a decreased number of EP4 receptors in the ductal wall. There's increased partial pressure of oxygen, which further causes ductal closure or contraction of smooth muscles. And the third is a mechanical clause. There's decreased pulmonary vascular resistance, resulting in a decreased blood pressure within the lumen of ductus, causing constriction of the ductus. Now coming to anatomical closure. In health, anatomical closure usually gets completed by day 5 to day 7 in most of the term-born neonates. In the remaining, it takes ultimately at a maximum 21 days to complete the entire process. It takes place in sequential steps, and the process in fact starts antenatally. This process of remodeling is likened to the process of atherosclerosis, which takes place in aging vessels. We ultimately have formation of intimal cushions or mounds, which basically obliterate the lumen and upon obliteration of lumen, there is hypoxia to the vessel wall, leading to release of factors like hypoxia-inducible factors, VEGF, PDGF, ultimately leading to apoptosis of the smooth muscle cells and fibrosis. To understand this process better, we need to know the histological aspects of ductus versus other medium-sized vessels. If you look at this particular figure, I'll basically name what all layers can be identified. We have an endothelial cell layer, then we have internal elastic lamina, a media, and an adventitia. If we notice, the internal elastic lamina is basically split into two layers, and there is some tissue which is present in between. There's an extracellular matrix basically which is present in between the split internal elastic lamina. Then we have media, which is basically made up of smooth muscle cells, and we do not see any elastic fibers at all. Again, because of the split internal elastic lamina, we have a potential space which has been created between intima and media. This particular potential space is called subendothelial region. Now let's compare this with a normal medium-sized vessel, say aorta. Looking at aorta, we have internal elastic lamina, which is completely adherent to endothelial cell layer and also to the media. And within media, we see a lot of elastic fibers which are present. And we do not see any potential space between intima and media, so there is no subendothelial region. Why do we have these differences? Number one, coming to a lot of elastin which is present within the media. We have a lot of elastin here because this particular vessel all through the life has to bear with mechanical and hemodynamic stresses. If elastin wasn't there, the vessel would collapse. But for ductus, the absence of elastin aids in collapsing. And in fact, if there's an elastin disorder wherein it is abnormally laid within the ductal media, the ductus remains patent. Number two, we have a potential space which is subendothelial region. This subendothelial region in fact begins to form antenatally. Intima all through the gestation is in fact very thin. It is not split antenatally. Just before birth, a few weeks before birth, there is migration of extracellular matrix within the intimal layer. So we have a lot of hyaluronic acid which gets laid within intima. Now this hyaluronic acid absorbs a lot of water, in turn splitting intima into two layers. So we have an internal layer, an external layer, and between these two layers we have a lot of extracellular matrix. After the laying of extracellular matrix, we develop a lot of potential space which is called subendothelial. The subendothelial space, it gets then invaded by smooth muscle cells which migrate from media into the intima, disrupting the integrity of internal elastic lamina and formating primitive intimal mounts which basically project into the lumen of ductus. This entire process, as I told, it begins antenatally, but postnatally this gets accelerated and accentuated very fast, ultimately forming intimal cushions which obliterate the ductal lumen. Once the ductal lumen is obliterated completely or sufficiently enough, it promotes hypoxia to the ductal wall. The inner layers of ductal wall are basically supplied with nutrients via the blood which is present within the ductus. Once the lumen gets obliterated via the intimal cushions, there is less and less nutrient supply to the inner layers, and this inner layer suffers from hypoxia, leading to release of HIF, VEGF, PDGF, and ultimately leading to fibrosis and apoptosis. But one might question, what about vasa vasorum? Vasa vasorum should be preventing this hypoxia from happening. Well, what happens is, vasa vasorum is actually meant to supply the outer layers of ductus. It is meant to supply adventitia and the inner layer of media. The other portion which is left is also known as avascular zone. It does not have any blood supply. It only receives nutrient supply by diffusion from luminal blood. Once intimal cushions are formed, this blood supply is cut off. But this blood supply should still be there. Maybe not to this region, but this region should be receiving blood supply. But that also doesn't happen. What happens is when the ductus contracts functionally, when there is smooth muscle contraction, so we have this particular smooth muscle layer. The outer layer is circular layer and inner layer is longitudinal. So once the ductus contracts, it not only constricts, it also shortens because we also have a longitudinal layer. And along with this constriction and shortening of ductus, what happens is the vasa vasorum which are present over here, they get constricted as well. So we do not have blood supply from here, we have no nutrient supply from here, and the most vulnerable region which or the watershed region which is present, it happens to be lying within the media, tunica media. In the middle of tunica media is the region which is most vulnerable to hypoxia. So this vulnerable zone should be present for all the anatomical changes to happen. If we have no vulnerable zone, anatomical closure will not happen. All the cascade of events which is started with hypoxia leading on to fibrosis, all of that needs this vulnerable region. For a fetal ductus to need blood supply via vasa vasorum, the thickness of the ductal wall should be more than 500 microns. A 24-weeker fetus has a ductal thickness of 200 microns and it is sufficient for that ductus to receive nutrients via the luminal blood. A 28-weeker fetus will have a ductus which is 480 microns thick, and for this fetus also the luminal blood will suffice. There is no need of vasa vasorum for these fetuses. These kids, if they are born prematurely, they'll only have a functional closure. Since they have no zone which can suffer from hypoxia, or they do not have any vulnerable zone, they only have functional closure. Or they need a very high degree of constriction of smooth muscles or functional closure. A very high threshold is required for them to develop a sufficient amount of hypoxia to develop the further cascade and changes. And they'll keep having prostaglandin storms because they'll keep having maybe sepsis or necrotizing enterocolitis, and this prostaglandin storm will further undo all the changes of functional closure. So basically it is a very rough course for such kids. To make this concept more dynamic, let's just look at a few diagrams which will make this concept more clear. This is a full-term ductus. Antenatally or prenatally, it is 1000 microns thick antenatally with a good blood supply via vasa vasorum. Up to 500 microns thickness, vasa vasorum will be supplying blood. And the inner layer or avascular zone will also be 500 microns because this entirely is 1000 microns. Postnatally, upon functional closure, in lieu of lumen, the ductal wall thickness increases to 1250 microns. So the luminal diameter is compromised because of the muscular contraction, and postnatally we have 1250 microns thickness of ductal wall. The vasa vasorum get constricted, and therefore the avascular zone functionally extends to the entire thickness of ductus now. The center of wall being of the wall, this region being the most vulnerable zone, and this is where the anatomical changes begin. Now compare this with the 28-weeker ductus. In this 28-weeker ductus, it is 480 microns thick already, and therefore it does not require any vasa vasorum. Postnatally, it will become 670 microns in lieu of the contraction, functional closure. But because there is still no vulnerable zone, it will not, or it will with difficulty undergo anatomical closure. So such a ductus, it requires a very high degree of smooth muscle contraction compared to a term ductus to cause hypoxia to the wall enough to begin anatomical changes. And thus, to sum up, a preterm ductus does not have intimal mounts or cushions to begin with. They are more prone to reopening because of their associated pathologies like sepsis and NEC, and they require greater thresholds of functional closure to begin the process of anatomical closure. That's all for today. In the next lecture, we'll learn about various clinical presentations of the